Food poisoning is a frequent cause of sudden illness. Symptoms include nausea, vomiting, diarrhea, and abdominal pain, often beginning abruptly. Nurses should ask key questions about what was eaten, when symptoms began, who else may have shared the food, and whether there are neurologic symptoms or fever. Management focuses on specimen collection, monitoring respirations, consciousness, blood pressure, and muscular activity, and correcting fluid and electrolyte imbalances from vomiting and diarrhea. Treatment starts with clear liquids and advances gradually to bland food. Antiemetics may be prescribed, and nurses must be vigilant for complications such as respiratory paralysis, seizures, and shock. Prevention and patient education remain central to public health. Substance use disorders make up another major category of emergencies. Patients may present intoxicated with cannabis, synthetic drugs, bath salts, inhalants, or stimulants. These substances can trigger unpredictable neurologic and cardiovascular effects. Nursing care includes securing the airway, monitoring vitals, seizure precautions, and maintaining a calm, safe environment. Because patients may arrive agitated or violent, staff safety and de-escalation are vital. Beyond stabilization, referral for substance use treatment is essential. Acute alcohol intoxication is one of the most common ED presentations. Drowsy patients may be allowed to rest, but airway protection and monitoring for central nervous system depression are essential. Blankets prevent hypothermia. If the patient is noisy or combative, sedation may be required, but careful monitoring for hypotension and decreased consciousness is mandatory. Alcohol can mask other illnesses such as head injury, pneumonia, or seizures, and intoxication itself raises the risk of aspiration and infections. Many patients need hospitalization or detox referral for full evaluation and ongoing support. Alcohol withdrawal syndrome is an equally critical emergency. It occurs after abrupt cessation of prolonged alcohol intake and can range from mild tremors to delirium tremens, which carries a high mortality rate if untreated. Symptoms include anxiety, agitation, tremor, insomnia, irritability, incontinence, and elevated vital signs. About 5% of patients develop delirium tremens, presenting with terrifying hallucinations, hyperthermia, tachycardia, hypertension, and profuse sweating. Delirium tremens typically begin within 48 to 96 hours after the last drink. Management aims to provide adequate sedation and support while preventing injury and collapse. Benzodiazepines such as lorazepam or chlordiazepoxide are commonly used to reduce agitation, prevent seizures, and promote rest. Haloperidol or midazolam may be added for delirium tremens. The patient is observed in a calm, well-lighted environment, with staff nearby for reassurance and reorientation. Illusions and hallucinations are explained to maintain contact with reality. Restraints may be necessary if the patient becomes violent, but only as a last resort. When used, they require continuous one-on-one observation and frequent checks to protect skin integrity, circulation, and breathing. Fluid losses from sweating, vomiting, and hyperventilation must be replaced with oral or IV fluids. Blood glucose should be monitored closely since alcohol depletes glycogen stores. Patients may require parenteral dextrose, orange juice, or sports drinks to stabilize glucose. Vitamin therapy and a high-protein diet help counter nutritional deficits. Because withdrawal is both a medical and psychosocial crisis, patients should be referred for rehabilitation and long-term treatment. Drug overdoses are another emergency. Cocaine can lead to chest pain, arrhythmias, seizures, and hyperthermia. Opioids produce pinpoint pupils, respiratory depression, and coma, reversed with naloxone. Barbiturates and sedatives depress the central nervous system, leading to ataxia and respiratory arrest. Nurses prioritize airway and circulation, administer antidotes, and provide continuous monitoring. Inhalants are particularly dangerous because they are household products like gasoline or canned air. Methods of abuse include sniffing, huffing, or bagging. Symptoms range from dizziness and euphoria to arrhythmias, seizures, and sudden death. Nursing care centers on airway support, oxygen, arrhythmia treatment, and psychiatric referral. Amphetamine-type stimulants such as methamphetamine or MDMA can cause hyperactivity, seizures, paranoia, and cardiovascular collapse. Care includes IV access, GI decontamination if recent, benzodiazepines for agitation, antihypertensives for blood pressure, and antiarrhythmics if needed. Patients should be placed in a calm, quiet space with reduced stimulation. Hallucinogens like LSD, PCP, and ketamine distort perception and can provoke violent or self-harming behavior. Nurses ensure airway and circulation, use calm reassurance, and provide sedation with benzodiazepines when necessary. PCP may require prolonged observation due to unpredictable effects. Sedatives and hypnotics, including benzodiazepines and flumazenil, can cause respiratory depression, coma, and circulatory collapse. Management involves airway stabilization, IV fluids, gastric decontamination if early, and administration of flumazenil as a reversal agent. Psychiatric referral is essential. Salicylate poisoning, usually from aspirin, causes tinnitus, hyperventilation, fever, metabolic acidosis, and coma. Acetaminophen overdose, common with both prescriptions and over-the-counter products, can cause liver failure and hypoglycemia. Treatment for aspirin toxicity includes activated charcoal and alkalinization of urine. For acetaminophen overdose, N-acetylcysteine is the antidote. Tricyclic antidepressant overdoses produce arrhythmias, seizures, hallucinations, and coma. Nurses manage airway, cardiac monitoring, activated charcoal, and sodium bicarbonate for arrhythmias. Psychiatric referral follows stabilization. SSRIs and other antidepressants may cause serotonin syndrome, especially when combined with certain drugs. Signs include agitation, seizures, hyperthermia, hypertension, and diaphoresis. Treatment includes activated charcoal, seizure precautions, benzodiazepines, and supportive therapy. Finally, anabolic steroid abuse can cause electrolyte disturbances, mood swings, violent behavior, depression, and long-term organ damage. Supportive care, psychiatric referral, and protection from self-harm are essential.